Okay, I think we should get started. My name is Yao Zuobang. I'm from Duke University. So my co-chair, Hongmin Qi Borshi, couldn't make it, so I'll be chairing the session by myself. So this particular session, we're going to focus on so-called the precision screening. And this really highlight the major investment and achievement of Taiwan medical community in terms of the early cancer detection and early cancer detection and prevention. So this is highlighted by the two really important discovery, probably most of you know already, in relationship to the H. pylori screen treatment and prevention of gastric cancer, and the other one is low dose CT. So this is really important part. I think really highlight what we have done in the last 10, 15 years that what Taiwanese community has done. And this impacts not only to the local community, because most of the things has been now applied covered by health insurance. Also, I think it has really important implication for the overall international community as well. So we're going to have three speakers today, but I must say that two of them is not here yet. So we're going to have a switch order a little bit. So we're going to have the first speaker, Director Chiu from National Taiwan University. So he's going to talk about really the really ingenious way to use the fecal sample to do screening for both the blood as well as H. pylori. So really, one stone, two birds type of assay. Okay, we'll give it to Dr. Chiu.
Thank you very much, Professor Yao, for the kind introduction. So it is my great pleasure to be here to share our experience of colorectal cancer screening in the past 20 years. And I have been the principal investigator of this screening program for 10 years. So there are so many information that I want to share with you. So with the first step, success in reducing colorectal cancer mortality, it's about time for us to move forward to the next step, the precision screening. So today, I would like to put more emphasis on this. Okay. So first of all, I would like to remind all of you that the ultimate goal of colorectal cancer screening is to avoid colorectal cancer death by detecting colorectal cancer at a curable stage. And nextly, if possible, we want to detect and remove adenoma and avoid the occurrence of colorectal cancer. But the problem is how much we would like to spend to avoid one cancer death or one cancer. So this is a very important issue that we should address in this moment. So colorectal cancer screening is one of the cancer screening program worldwide, standing on a very strong basis of clinical evidence. So 30 years ago, we have a randomized control trial using the chemical FOBT, fecal occult blood test. And we have several important colonoscopy trial, and we have synthesized this evidence for systematic review, meta-analysis, and we also have a decision analysis for colorectal cancer screening, and finally reach the policy making. So our screening program started in the year of 2004. So this slide shows the 10-year result of this screening program. And we can see that colorectal cancer mortality had reduced by 35%, and the incidence of advanced stage colorectal cancer had reduced by 29%. So the reduction in incidence of advanced stage cancer not only represent a life saving, but also a cost saving effect of the screening program. So from this year, our Taiwanese government lowered the age to initiate screening to 45. So there's a slogan, 45 is the new 50. So Taiwan is the third country that lowered the age to initiate colorectal cancer screening. So initially, probably 3 or 4 years ago, I proposed to the government whether we consider to lower the age to initiate screening to 45, following the step of United States. However, at that time, the response that I got is, let's see how other countries do. So, however, Taiwan had one of the highest colorectal cancer incidence in the world. We have probably second or third colorectal cancer incidence, either in male or female. But very lucky, we had a very old cohort that has been followed up for 20 years. This was the cohort of the community screening in Keelung and Tainan. So we can see that when we compare those who attend screening from 40s and those who only attend the screening after the age of 50, you can see that the incidence of colorectal cancer and the colorectal cancer death was 21 to 23% lower, and for mortality, around 40% lower compared with our previously way of screening starting at 50. So this study constitutes the scientific basis of our screening policy. And this is the classical definition of organized colorectal cancer, organized screening program. As per the definition by IARC, organized screening program need to have a specific age range for screening and the specific method and a fixed interval for screening. However, it's about time for us to move forward to the precision screening because the risk of individual in terms of colorectal cancer risk is different. So our recommendation for the age to start screening actually was based on the pooled or approximate risk estimated based on the population data. So you can see that in the US or in the UK or even Taiwan, we have a universal age cutoff to start and stop screening, and also have using the same screening modality and also using the same screening interval. So precision is a tool to address diversity. So we should bear in mind that diversity is not the exception, but just the norm of the nature. So if you look at the human health, genetic predisposition contribute to the risk of disease. However, it has a very wide range. And you can also see that social circumstances, environment, and the behavior also have a wide range of diversity. And even the healthcare, the quality of healthcare is not equal. So this constitute the demand and the necessity of addressing diversity and the precision cancer screening. So with the aid of modern technology, including AI and other development, we are now able to combine gene, environment, and lifestyle factor to improve our health. So the reason why we need precision screening is that it can tailor a screening strategy based on individual risk rather than applying a one-size-fits-all strategy, thereby maximizing the effectiveness and reducing the cost and achieve a higher cost effectiveness. And we can also avoid overdiagnosis and overtreatment. So if you look at the colonoscopy screening, this is the mainstay screening in the United States. 70% of the people who receive colonoscopy has a negative finding, and only the remaining 30% has a neoplastic finding. If you look at the FIT screening, which is the mainstay screening in Asia Pacific and the EU, in the general population, the prevalence of colorectal cancer is 2 to 3 out of 1,000 population. However, in FIT positive cases, 5% had invasive cancer, and 1/5 of them had a high-risk adenoma. So this is quite different. So if you further look at the cancer that diagnosed within the Taiwan colorectal cancer screening program, then 70% of the cancer was screen detected, and 18% were colorectal cancer that occur after a negative FIT. And for some people who had positive FIT and compliant to colonoscopy, there are some cancer occur even after colonoscopy. We call it post-colonoscopy colorectal cancer, PCCRC. And some people just think they do not have chance to get colorectal cancer. So they are not compliant to colonoscopy even after positive FIT. So this is a very different population. So there are so many tools to address precision or tailored screening in different kind of cancer. But today I would like to focus on colorectal cancer, especially using the screening modality that we have in our hand. So this slide shows the wide range of diversity in terms of colorectal cancer risk, considering the polygenic risk score and other risk factors. So currently, our screening program just considered the age and the family history, and the age cutoff to start screening was the same for male and female. But actually, male has a 1.6-fold higher risk of colorectal cancer compared with female. So previous studies have shown that if we put polygenic risk score and the environmental factor and the family history together, its performance was much better than just considering the family history. However, whether polygenic risk score approach is cost-effective is another issue. So firstly, the performance of polygenic risk score should be high. So you can see that it can only be cost-saving when its AUC is above 65 or even 70. And secondly, in a cost-effective analysis, the polygenic risk score approach was cost-effective only if the adherence to screening is perfect, 100% adherence and without any cost. So this is not practical. And this is the screening tool that we use for population screening in Taiwan and most of the Asia Pacific and the EU country. So you can see that in FIT positive population, the risk of adenoma or any neoplastic lesion was 40% higher compared with the general population, and the risk of advanced neoplasm, including cancer, was 4 to 5 fold higher than the general population, and if only confined to invasive cancer, then such risk was 20 to 30 fold. So let's talk about fecal hemoglobin. Fecal hemoglobin level actually is the quantitative measurement of FIT. So it did not just be used for determining who should go for colonoscopy and who don't need. But we can use this quantitative measurement for further tailor our screening behavior. So we have known that the hemoglobin concentration was positively associated with the risk of having advanced neoplasm or even cancer at colonoscopy for a very long time. So you can see that the higher the fecal hemoglobin concentration, then the likelihood of having invasive cancer at colonoscopy was higher. So our previous study by Professor Li Jia, he's also here, you can see that the longer the duration from FIT to colonoscopy, then there were higher risk of colorectal cancer or advanced stage colorectal cancer being diagnosed at colonoscopy. And we also found that such risk was positively associated with the quantitative measurement of FIT. And we also found that those who were not compliant to colonoscopy after positive FIT had a 64% higher risk of dying from colorectal cancer. And such risk, again, was associated with the level of fecal hemoglobin. So the higher the fecal hemoglobin, then the higher the risk of dying from colorectal cancer if they did not go for colonoscopy after positive FIT. So nowadays we tell our patient, if you don't go for colonoscopy after a positive FIT, then you will die. But in the future, probably we can tell them you will die because you have a very high hemoglobin concentration. So the only solution is go for colonoscopy right now. So another very interesting finding that I want to share with you is applying this quantitative measurement during the COVID pandemic. So for some reason, you can see that the red line, this refers to the rate of colonoscopy referral for those who had a very high level of hemoglobin concentration. So you can see the colonoscopy rate was much lower for those high hemoglobin concentration group. I don't know why. Probably related to risk factor, and this risk factor was associated with their health behavior, like smoking or high intake of processed meat or something. So during the COVID, after the first wave of the outbreak, we had a national meeting to decide we should prioritize those with higher level of fecal hemoglobin concentration for colonoscopy, because at that time we had a constrained colonoscopy capacity in Taiwan. So in this way, although we perform a far fewer colonoscopy, we detected a similar number of colorectal cancer during the pandemic. So this is one of the successful application of this quantitative measurement to improve our population health. And our previous research also found that the risk of developing colorectal cancer or advanced neoplasm was associated with the baseline hemoglobin concentration, even if the concentration was lower than the positive cutoff. So in a later study, we found that such concentration was associated with the risk of developing colorectal cancer, even after colonoscopy, and either in those with neoplastic finding at baseline colonoscopy or those without. And this slide shows the current scheme of surveillance after colonoscopy, and either in the UK guideline or in the US guideline. Basically, we tailor the patient to go for surveillance colonoscopy after polypectomy based on the size and the number and the histology of the resected neoplasm. However, in our recent study using our national cohort, we further stratify our patient in high-risk group and in low-risk group based on their baseline hemoglobin concentration in terms of the risk of incident colorectal cancer. So in this way, we can shorten the surveillance interval for those with higher risk and extend the surveillance interval for those with low risk. So in this way, this is just a simulation and estimation, but we could successfully reduce the demand for colonoscopy and concurrently reduce the risk of colorectal cancer, either using the US or using the EU surveillance guideline. And another application of fecal hemoglobin concentration is to guide inter-screening interval. So for those people who had a very low level of fecal hemoglobin concentration, probably they don't have to go for FIT screening every 2 years. We can extend their inter-screening interval to 4 years or 6 years. So given a colonoscopy rate of 60%, in this analysis, we found we can reduce the number of FIT testing by 49% and reduce the colonoscopy workloads by 46%. And we also explore the feasibility of using the age and the gender specific cutoff for colorectal cancer screening. So you can see that this age and gender specific cutoff can maximize the detection of cancer, but with the similar demand for colonoscopy. So this slide summarized the application of FIT in the colorectal cancer screening, not just to determine the positive cutoff for colonoscopy, but use it in every aspect of the screening workflow. And finally, I would like to address a little bit about other diversity in colorectal cancer screening. So in this national polyp study from the US, you can see that those who had adenoma detected at the baseline colonoscopy has a higher risk of developing cancer even after polypectomy. So colonoscopy is not just to inspect the colonic mucosa or just to resect adenoma. It is a tool for risk stratification. So I have shown this slide previously, but I just to let you know there is another diversity in healthcare. So previous study from Poland and in the US, it showed that the performance of endoscopies is related with the risk of developing cancer after colonoscopy. So you can see that ADR, adenoma detection rate, which is an indicator to measure the performance of endoscopies. So the lower the ADR, then the higher risk of developing cancer or developing advanced stage cancer, or even lead to higher risk of colorectal cancer deaths. So the same finding was also observed in Taiwan colorectal cancer screening program. So you can see that in a hospital with lower ADR, then there were higher risk of colorectal cancer incidence and the colorectal cancer mortality. So we don't want to expose our patient to a risk like gambling or like playing the Russian roulette. I don't know how many of you have ever seen this Oscar-winning movie, The Deer Hunter. So the bullet exactly is the PCCRC or colorectal cancer death. So we have to diminish the diversity or the disparity in the performance of our healthcare service. So this study from Netherlands showed that even the high-risk population, high-risk patient, if the colonoscopy was performed by good colonoscopy or high performer, then the risk of developing PCCRC was much lower than the low-risk patient, but performed by low performers. So I think this is a very strong and important message conveyed by this study. So what we have done is to push the digital transformation of our screening program. So we firstly standardized our colonoscopy reporting format, and we asked all the endoscopy in screening program to use the drop-down menu to input the important information at colonoscopy. So you can see that things are getting better. our colonoscopy quality is improving, and our PCCRC rate is declining. However, we still see a diversity in the number of colonoscopy being detected at colonoscopy. So now we monitor ADR. ADR is measured by at least finding one adenoma, but some doctors know that they already fulfill the audit criteria. So they remove one adenoma and we show their scope. However, leaving the adenoma or even high-risk adenoma unresected in the colon may cause high risk of PCCRC. So you can see that even in the year of 2022 to 23, the diversity in APC still existent. So you can see that there are so many one and done hospitals in Taiwan, and even in a few medical centers. So this is a very important thing that we have to fix in the upcoming years. And we also have to consider the different screening behavior, and some of the individual just use a different screening modality, use the FIT or colonoscopy, self-pay colonoscopy interchangeably. So I think in the future analysis, we should consider a different screening behavior and also take into account different screening modality. And finally, I would like to talk a little bit about the precision primary prevention. So now that we know a Fucobacterium nucleatum, a pathogen in our gut, is associated with the risk of colorectal cancer. But such a risk is associated with Western diet only when this bacteria is existent. That means we always advise patients to follow a prudent dietary pattern, but it's only worse for those who have Fucobacterium nucleatum, and it is also the same case in the dietary inflammatory pattern. So we know that physical activity is associated with the risk of colorectal cancer. So in the future, we can apply the smart technology. And also we can analyze the gut microbiome in toilet. So this is my final slide. So in the future, we should consider whether we can apply the precision screening tool in our screening activity. Firstly, we should ensure the security and the trust by the people. And also, we have to make all the things digitalized. And the most important thing is that we have to consider feasibility and whether the screening tool in our hand can be used for this purpose. Thank you very much for your kind attention.
Thank you. Thank you so much for the wonderful talk. The bad news, we don't have time for any questions. The good news, our second speaker is here. All right, thank you. So if any question, we'll talk to Dr. Chiu, we can talk afterwards.